Can you see? So can you see my screen?
Yeah, we've got it. Thanks, Bashir.
So thank you very much for having me here. The introduction was done by Ruby, so I will directly start the presentation. Somali region is one of the 10 states, Ethiopia, that contains Ethiopian federal states. So in Somali region, it also have 11 subzones. So Dola zone is one of that 11 zones. So Dola zone is where Tea Team surveillance is based. So Dola zone has a population of 300,000 people in, for instance, of 2007. 30%, 37% of people live there are purely pastoralists. There are other parts of pastoralists, but that number is the number of pure data pastoralists. MSF has been there since 2007, and it implemented different services, including primary and secondary care. But in 2007, due to an emergency crisis, it shifted its strategy to emergency response and surveillance. So the emergency subsided in 2018. MSF started a system of surveillance that was supposed to detect and respond in a timely manner to disease outbreaks and other emergencies. So, as you can see from the picture, in the surveillance area, MSF were doing surveillance purely in some sites in the blue area, and integrating surveillance with other MSF services in the red, in the upper red area mobile clinics. So the surveillance system, Team surveillance system, has 4 components: 2 community-based and 2 non-community-based surveillance. So, namely, they are community indicator-based surveillance, community infant-based surveillance, health facility indicator-based surveillance, and other infant-based surveillance. So, when it comes to events under surveillance or event of interest, community infant-based surveillance were surveillance in the following events: community suspected cases of measles, WD, and HES, clusters of cases of the same illnesses, increased number of deaths, concern about malnutrition, animal sick of and animal die of, population movement, and other unusual events such as flooding. So among those events, there were 2 events that were context-based. Concern of malnutrition was basically how communities and community others see a concern of malnutrition. So sometimes they see concern of malnutrition as a lack of market that induces less food and children are getting wasting, or and it's concerned community. So they report to us, then we do our verification. And population movement was kind of entire zone. People were usually on the move, so they are moving every year, every time of the year. So it is a bit tricky to identify when you see a movement, whether it is induced by climate, extreme climate, or just other things. So we were surveillancing every population movement, small or large. Community indicator-based surveillance were having the following events: suspected AWD, suspected measles, suspected HES, malnutrition, and suspected, and we adapted mid-2020, suspected COVID-19. So the EWAR part of the surveillance system is, as you can see from the chart, is into 2 types. In the upper types, the 4 different types or components of the surveillance each has its own source of information and method of gathering. But when it comes to after verification and below, they join all together and use the same system. So from the right, community event-based surveillance uses key informants, usually community volunteers, while community indicator-based surveillance, next one, uses community health workers. And health facility indicator-based is review of MSF mobile clinic registration books and DHIS system. And other infant-based surveillance is a collaboration and meeting with other actors, mainly FMOH, mainly MOH in its different levels, regional level, zonal level, and district level. So that was the system and the EWAR part. When it comes to the methodology we use to evaluate, we use mixed methods. First one was a retrospective analysis of all surveillance data that we stored during the study period from 2019 to 2020, and focus group discussion with community members, key informant and community leaders, and in-depth interview with MSF surveillance staffs. So the attributes that we used were usefulness, simplicity, flexibility, timeliness, completeness, acceptability, positive predictive value. So in terms of usefulness, you can see we received a total of, we identified a total of 1,206 signals. We followed up 271 of them. We mean that follow-up we recorded and follow-up for further processes. So among the 271 we followed up, 172 of them were verified as fit for assessment. So among that, assessed 60 of them become an alert that were worth of response, and 31 of them were responded. So generally, there were no major emergencies during the evaluation period. But when we say response, we still mean that smaller responses that we launched in order to prevent larger emergencies. So when we say response, we mean that the flowing vaccination campaign, advocacy for other actors, opening of new mobile clinics, treating measles cases, and providing NFI support for example, after floodings. So in terms of acceptability, when it comes to MSF staff interviewee, the staff said, as the quotation says, staff said when it comes to the normal time when there's non-emergency, the system were acceptable. But during hectic emergency times, the system were not simple, and all steps of the EWAR system or surveillance system were not all simple and easy for the staff who were implemented. So it was that one. And when it comes to community acceptability, we found, as also the quotation says, we found a community were mainly obsessed on for what, when after information, what they get. So the community were very curious if the information is going to produce benefits for them. They were very cooperative and it was acceptable. But if they see only the information is taken and no benefits for them, it was not cooperative, so it was less acceptable in that way. So, and an example is from a good example is from the next quotation is when there is a camel and health issue, and community expected for response, and they did not see any response. It shows them that it is not it's not acceptable to them. Sorry. Are you following me? Okay, so when it comes to timeliness, the proportion of signals verified within 24 hours of report were 80% in community event-based surveillance, 75% in community indicator-based surveillance, and 100% in health facility indicator-based surveillance, and other event-based surveillance was 80% around. So it was around the targets. But when it comes to risk assessment, we see that community in infant-based surveillance was 37.9%, and other event-based surveillance was 46%. So the two surveillance types that we have in significant number of signals flown up were both below 50%. And that attribute is positive predictive value. So the positive predictive value of all 4 surveillance types were very low, with other infant-based surveillance relatively higher than the other 3. But when it comes to positive predictive value per signal type, you can see measles and suspected EWA are relatively higher than other signal types. So they are still low, they are higher than other signal types. So we see some signal types that the positive value is 0, and we see others, suspected measles and suspected EWA are also low, but they are higher than the others. And from my understanding, one of the limitations of this study was we were not able to compare with other surveillance systems. So particularly in attribute of positivity value, we were not able to compare surveillance in the similar time of other actors, for example, MOS surveillance types. So the positivity value is not very informative. So when it comes to conclusion, the Tea Team surveillance system is useful. And we identified the following challenges: and acceptability and simplicity. There was complexity of data systems, and we need to improve collaboration with animal health actors during response, positive predictive value of signals, and timeliness of risk assessment. So the recommendation is to simplify the surveillance system. We simplify the surveillance system in terms of data collection procedures, both at collection level and at analysis level, by making the data electronic into COBO and using faster data analysis machines like our database. And we remove community indicator-based surveillance and focus on community infant-based surveillance in all locations, because community indicator-based surveillance generated less information than the other one. So we also plan or recommend to reduce the number of signals, and we recommend to strengthen collaboration with external actors, and in that means we strengthen other infant-based surveillance, including animal health actors. Thank you very much.
Thank you, Bashir. That was a great presentation. I'd also, so we can take questions from the audience. I'd also like to welcome Patrick Keating, who supported Bashir with this work, and he can also support with answering some of the questions. I hope, Patrick, you're on the line.
Yeah, I'm here. Happy to do that.
Great. So yeah, please raise your hand if you have a question. Bashir, can I ask you to stop sharing your screen? That would be great.
Thank you.
I can kick off while everyone's having a think about it. I think your work on the positive predictive values was quite interesting in that it demonstrates the low percentage of any of these alerts that are actually true events. Is that something that you expected, or that we see in other early warning systems, or do you think that was particular to this setting?
Thank you for the question. It is what we know is there was no major emergence during the evaluation period, and we were not kind of expecting a higher possibility value, high probability value, but our expectation was higher than this one.
Thank you. Hilary.
Hi, everyone. Thank you for that really interesting presentation. It was fascinating. I have a question a bit about your recommendations. So I'm wondering whether you have either had or anticipate any pushback on actually deciding to drop one of those surveillance components. So the community IBS, I think, is the one that you said you would look at removing. And I'm just wondering whether how you will explain that, and whether you think that there might be pushback from the people either involved in it or the communities involved in it. I also wondered on that line, seeing as the health facility IBS is also not, I think if I remember right, it's not up there. How will you talk to the authorities about that? Because obviously you can't drop that, but it's perhaps not contributing as much as one might imagine. Over.
Thank you for the question. If I understand your question very well, in terms of recommendation and dropping the community indicator-based surveillance, I am not sure what you mean pushback. If I think if you mean resistance from community, from just community members and other people who were involved, I think we are not predicting a pushback from a resistance from that part, because the information that we are using to decide to drop this part of this type of signal is coming from the same people. So, for example, we interviewed people and we sat with community members to identify that one. So we believe that we will not face a pushback. So on the other thing, we think that the surveillance system can continue without that component, and it's not a system that is not mandatory to continue with that. And we believe that we get better information for action than focusing on community infantry-based surveillance instead of just putting the energy on there.
Thanks, Bashir. I actually also have a question on that, but I'd like to give the floor to Freya and some of the people that are putting comments and questions in the chat. Freya, would you like to ask your question? Maybe she's not able to connect. Freya says it's a really interesting talk. Where exactly were the OEBS signals coming from? Apologies if I missed this in the talk. She has unstable internet connection. So she's asking, what are the sources of the OEBS signals? Bashir?
Yes, the source of OEBS or other event-based surveillance is other actors that are also having healthy or surveillance public health activities in the same area. For example, Minister of Health have three-level surveillance system, three-level healthcare system, regional level, zonal level, and district level. And all levels have their own surveillance, their own system of surveillance. So when in areas that we are not, our surveillance is not very strong, if they see things, they just communicate with us. And other partners also include WHO, also have their own surveillance people, surveillance focal people operational in the area. So we have a regular meeting and sharing of data from area that we are operational. We share with our surveillance, and we exchange theirs from us. So and also it's not necessarily only that too. Other actors, for example, nutrition actors, also just share with us. So that is where that's a source of OEBS.
So thank you for that, Bashir. So Freya's follow-up is, Ministry of Health and WHO tended to pick up actionable signals more often, or was MSF more likely to undertake a response if the MOH had picked up a signal?
MSF has an EBRA plan for four major emergencies: cholera, measles, and malnutrition crisis, and acute jaundice syndrome. So in that four areas, MSF has its own threshold just to respond if it is kind of an area that's above the capacity of the MOH. But MOH doesn't mean that this doesn't mean that MOH is not involved from any level. MOH is the primary response for everything, but MSF is the main support for these four scenarios, or for these four major things, particularly when it's a level where the MOH thinks that in terms of capacity or in terms of resource that they cannot launch an enough system. And WHO is also the main support for some parts, including focused on including like polio, measles. So each partner has a specific focus, and different partners share the entire public health picture. So through meetings, cluster meetings, and different meetings, the domain or the partner, for example, MSF for cholera of that particular domain takes the lead.
Great, thanks, Bashir. Can I ask a question about why you had so many different surveillance systems for EWAR, which I imagine was quite resource intensive, but a very good integrated outbreak analytics approach, by the way, because you're using so many different data sets.
Yes, I think Patrick will also just contribute this question, but from my understanding is the area is very when during start of this surveillance systems were very precarious area and having different settings. So the one surveillance system is good in for example, in highly pastoral rural area, and another surveillance system is good in settings, in certain populations, and where health facility are functional. And another one is still good in settings where in settled population where health facility is not functional, still existing but not functional. So that is my understanding. So if Patrick can add maybe some explanation.
Yeah, I mean, I think you've covered it, but I think mostly it was around coverage. By adding in the other event-based surveillance and I think other actors, we were able to have a broad review of what was happening in the zone. And similarly, with the community event-based surveillance, we were able to kind of access more locations and just get a broader kind of understanding what's happening in the region. Because previously, before we made these big shifts, we only had surveillance in primarily in locations where we had mobile clinics. So we had community indicator-based surveillance and mobile clinics. But this expansion really was to understand that issues in the zone can impact anywhere. So to have this broader coverage through these multiple surveillance components.
Great, thank you both. Hilary had a follow-up question.
Sorry to take some time. Yeah, it's just to go back a little bit. So thank you for the answer, Bashir, on the pushback from the community. I can understand that. I suppose what I'm finding really one of the interesting things here is that, as might be expected, the health facilities, if they have poor or weak human resources, I guess there's really quite seems to be, and I haven't got all the your slides in front of me, but there seemed to be quite a big difference between the health facility indicator-based and even the community-based indicator. Now, I can imagine that because obviously MSF has more input, perhaps, or more ability to combine or drop the community-based indicator, the community indicator-based component. But if you could argue that actually it's the health facility one that isn't contributing. And that may not mean dropping it, but it may mean looking at whether that component needs to be strengthened or how it can be strengthened. I know it's a tricky question, but that's I'd be interested to know what you think about that.
Thank you very much for the question. Apology. Patrick, can you please chip in and answer that question?
Yeah, no problem. This is a really good question. I think I guess this evaluation highlighted kind of one of the weaknesses of the system was how we were systematically documenting signals coming from the health facility and that they went through the whole process. I think signals coming from other event-based surveillance and all the community types were documented in a much more systematic way, and it was weaker the approach that was taken for the health facility. In terms of how we actually had to take a different approach to identify the signals for the health facility. We looked back retrospectively at our data in DHIS2, so it was a little bit different. So it's, so essentially the kind of the data collection processes need to be strengthened in order to get a kind of a more representative measure of the positive predictive value from the health facility data. But it's very much the thing we're working on now.
Great, thank you very much. Thanks.
Thank you all. I'm going to close the questions now. I just want to direct Bashir and Patrick to the chat box where Fung Pham has kindly offered support with Kobo. And there's an additional question from Freya. Perhaps you could bilaterally respond to those. I just want to move on to the next part of the discussion, which is really talking about IOA's role within early warning systems. So if I just go back to my slides, I hope, yes. So we've heard a lot of talks now about the different components of the early warning and alert and response systems, or EWAR systems. And there are synergies between integrated outbreak analytics and EWAR systems. They're both field-based approaches that leverage multidisciplinary collaborations. And they both aim to improve evidence-based decision-making. So the objective of the discussion in the last 15-20 minutes is really to document the added value of integrated outbreak analytics in EWAR. To sensitize EWAR teams to and outbreak response actors to the added value of IOA, and to support the future development of case studies for the continued development of the EWAR technical guidance in emergencies. So I wanted to open up the floor for discussion, and here I'm going to have to ask for Simone and Dante's support, because now that I'm showing my screen, I can't see the when people have their hands raised. But firstly, I wanted to explore which phase of an EWAR system could benefit from IOA or IOA components. And to help us out, I've borrowed this graphic from the new EWAR's guidance, but I borrowed the wrong diagram. Actually, it should be the box underneath that's highlighted, because that's where there's a natural fit for IOA in that phase of EWAR. So let me just go through the different phases first. First, we have this, I don't know if you can see my cursor, but at the top, we have the early warning component of EWAR, which is using IBS and EBS signals to create, to see if there are unusual signals. And that's what we've just heard in Bashir and Patrick's talk. And then if a signal is introduced, then it needs to be verified, and that's to ensure that there's no false rumors or artifacts or hoaxes. Then it becomes an event, and that needs to undergo risk assessment and characterization. So that's to see if it's a situation that could potentially become worse or become a public health event. And then it becomes an alert, and that undergoes, and that needs a response, which includes an outbreak investigation and control measures if deemed necessary. So IOA naturally fits into that outbreak investigation part, where it's not just about looking at the numbers, it's about looking for explanatory factors for the trends that we're seeing. But I wanted to open the floor for discussion as to whether that's the only phase of EWAR that could benefit from IOA, or even to expand on its role in outbreak investigation. I see we don't have any comments. Oh, right.
Hillary has her hand up.
Great.
Sorry, Ruby, I'm not,
No, that's fine.
maybe I'm not so familiar with how IOA is set up, but I actually was wondering whether there might be a role for IOA in the first part, because actually identifying and bringing up the events for a particular context, I mean, there may be very obvious ones, but the community may be able to feed into, or qualitative discussions with the community may be able to feed into actually what the early warning signs might be. It's just a thought.
Yeah, thanks for that, Hillary. I think you're right. Just to clarify that integrated outbreak analytics isn't just qualitative data, it's multiple data sets, and they can be quantitative or qualitative. And I think Bashir has just shown that in his talk, that the use of multiple sources of data to improve and create a more comprehensive EWAR system, which is what was set up in the Somali region of Ethiopia, improved the signaling for the EWAR system. So in fact, that demonstrated the benefit of IOA at that very early stage. So I think you're right, Hilary. You've got your hand up again.
Yeah, just to say then, yes, point well taken. But in that case, I would see that actually IOA actually fits in all three steps, because even the verification would need different access to different data sources, perhaps.
Yeah, that's a good point. And how would we see IOA being set up in that respect for the different phases? So this isn't a question to Hilary, it's a question to the group. Do we see any challenges or concerns about setting up IOA to support the different phases of EWAR? One of the concerns that I put here is the agility and the timeliness of EWAR systems. They inherently need to be fast and timely, and whether IOA has the potential to slow EWAR down. Is that a concern that we should have? Simone.
Thanks, Ruby. I mean, I think it would depend on how it's been set up. So for example, in the Ministry of Health and the GRC right now, we're setting up an IOA cell capacity full-time within the the General Direction for the Lutte contre la Maladie. And part of that then is IOA for EWARs, but it's for early warning. And so absolutely it will fit in, but it has to be already operational, and then it wouldn't slow it down. So one of the things that we're making sure is that there's 5 components that the Ministry of Health IOA cell will have, and one of them being IOA and early warning, and then it wouldn't slow it down. But I think you couldn't set it up and try and retrospectively do anything. So it just needs to be something that is like smoothly operating to be able to work. But I mean, we'll hopefully be able to have feedback on how it's worked in some months. So I do think it is possible, but it needs to be really part of a Ministry of Health bought-in system as well to make it useful.
And Patrick, would you like to? I've just managed to get access to the chat box. Patrick, would you like to speak to your question or your comment?
Yeah, I mean, I think just generally, even the example from the Tea Team system, one of the weaknesses was around collaboration with animal health. We were getting the signals about death and illness in animals, and it's so linked. It's a very much one health setting. Animal health and human health are so connected, but then the lack of the strong collaboration means that the whole approach can be challenging. So there needs to be an investment up front with a lot of these other sectors in order to make these systems really functional, because otherwise it can just be a collection system, and that leads to no response, reduces the acceptability, and then can fall apart ultimately. So I think the IOA is really essential for it to function well, that integration across multiple sectors.
Yeah, good point, Patrick. Hilary, you made a point in the chat. Did you want to follow up on that?
I think actually probably Simone and Patrick have addressed that idea of that I was thinking of, is that in setting up the EWAR, you kind of need to have an eye to those multiple data sources.
Yeah. And that's something that I was going to move on to. So that's a good point, Hilary. Lauren, did you want to speak to your point?
I think Simone and Patrick have already said it, just multi-sectoral, multidisciplinary data pipelines in use sort of at the signal level. So to Patrick's point, collaboration with One Health partners, weather partners, I guess, social scientists to understand migration patterns, all of those things integrated at a ministry level.
Great, thanks. Esther, would you like to speak to your point?
Yeah, I've heard, by the way, that my microphone makes me sound as if I'm a chain smoker. So if it sounds like that, I'm not a chain smoker. No, I was just pointing out in the chat that I think during the 10th Ebola outbreak, where I was involved together with Simone as well, I think one of the things that by taking a more of an IOA lens, we try to kind of dig a bit deeper into delay in treatment seeking and trying to understand, okay, why are certain individuals, for example, children, often delayed in being identified and or seeking their parents seeking treatment. Now, that might more have to do with surveillance, but I think part of it would kind of help it inform and see, okay, how can we maybe enforce community level surveillance and kind of engage the community better in raising alerts. And I think this would then be part a bit more of the EWAR system. So kind of, I think seconding also what Patrick has been saying, that how important it is to ensure that everyone is on board to have an effective EWAR system. Yeah, so that was my main point I wanted to make. Over.
That's great. Thank you, Esther. One of the points that I wanted to discuss as well was the systematic collection of contextual data, which we know is important, particularly for outbreak investigation, but also as we've just explored the other phases of an EWAR system. And we know that contextual data isn't collected systematically. And do we know, or can we explore potential mechanisms for collecting contextual data systematically and community data as well? Or do we already know of some systems that are doing that? And then the add-on to this as well is we know that there are digital tools available for EWAR, like EWARs in a box, but that at the moment it doesn't collect contextual data or community data routinely. And to follow up from previous working group calls on community data, how can we incorporate that contextual and community data into EWARs in a box or digital tools to support integrated analysis? Simone has just put Fong on the spot. Would you like to, how brave do you feel, Fong?
Thanks. No, I think this is, I think it's a really important questions, and our team have tried to do this through our, we have quarterly system of data collections up until this past year in the DRC to collect some of these indicators that, about conflict, for people perception, some of the others. But I would have to say that it's, I think it's work that needs more effort, because I think these contextual data is so important. It does influence a lot what's going on. And I think speaking to the other about, how community data as well. So I think that is much needed. We're not very good at collecting those. And maybe I think it's, right now we're doing, using an active data system to collect those data. I wonder if there's another way to do it passively and more systematically. So I think this is something I think needs strengthening, but I wouldn't say that we have a solution for that right now.
No, I would agree with that. I think that's definitely an area that we need to work on and strengthen, and all ideas are welcome. And Hilly, just would you like to comment on your comment in the chat?
Yeah, very quickly, because unfortunately I have to go, but I was reading something about participatory advisory groups where the idea is that is a bit more structured than a focus group in the sense that you actually recruit what you might see as a representative group, but it's not huge. It may be 10 or 15 people that then meet specifically to to discuss health issues in that community at a sort of regular basis. Of course, you can get into things like this. You end up, you have to think about bias and representativeness and so on, but it was really to try and have a long-term feeding into a program that could raise issues or raise contexts rather than, and I hear what Fhuong said, that, I mean, quarterly, I can imagine that brings a lot of information, but in the timeliness, then you'd have to filter a bit to know what you were getting. Anyway, it's just, I haven't read that much about it, but might be a way to think about it.
Yeah, and I'm not sure, but there is a section in the new EWAR guidance that's talking about community participation. It'd be important to have that kind of information in there, I would have thought. Patrick, would you like to speak to your point?
I'm also happy if Bashir does, but I think because he's the one who was actually running the system for the last 2 years. But essentially, the reason why the T team is called the T team is because the team go on a regular basis to all the various villages on a bi-monthly basis to the villages under surveillance. And because of the nature of the pastoralist population, they will come from bush areas. And again, Bashir can speak far better to this than I can, to the tea rooms, and was an opportunity for information exchange, also asking about contextual things about healthcare access and illnesses, but also population movements and broader concerns of the community. And again, Bashir, please jump in. But yeah, so that participatory approach was also built into that system.
That was actually going to be one of my questions, why it was called Tea Team. So thank you for answering that. I'm sure that a lot of people were thinking the same thing. I think that's a really nice close to the session, unless there are any more questions. Thank you so much for your participation today, and really enjoyed the talk from Bashir. Thank you so much for managing to call through from Nigeria. And there won't be an IOA working group call on the 15th because that's Good Friday and many people will be out for the Easter holidays, but we will have another call on the 29th, and it'll be interesting. It'll be exploring that very early phase of the EWAR system. So we're going to be talking about prediction and risk mapping and the role of IOA in that. So stay tuned and we'll send out an email about that shortly. Take care. Thank you so much.
Thanks, everyone.
Thanks. Bye-bye. Have a nice day.